Dr. Badr, shall we start?
Yes, please, Hiba.
Okay. Dear participants, good morning, everyone, and welcome to our workshop. My name is Hiba Jabarti from Saudi Patient Safety Center. You will be hearing a presentation from Dr. Badr Shaddadi, Head of Culture Improvement in the Saudi Patient Safety Center, and Dr. Rakan Al Mughir, Head of Healthcare Provider Empowerment in the Saudi Patient Safety Center. Also, Dr. Rawan Sultan, Certified Saudi Board of Emergency Medicine, Head of Learning and Reporting in the Saudi Patient Safety Center, Chairman of the Saudi Patient Safety Center's Continuing Professional Development CPD Committee. And our last speaker will be Dr. Tarq Al-Ubaida, Certified Saudi Board of Emergency Medicine, Senior Patient Safety Specialist in the Saudi Patient Safety Center. They will be speaking to us about root cause analysis that will provide the participants with the goal of the root cause analysis process, which is to find out what happened, why it happened, and how to prevent it from happening again. Because our culture of safety is based on preventing, not punishment. Root cause analysis teams investigate how will patients' care system function. Starting with our doctor, Dr. Badr Shaddadi, Certified Saudi Board of Emergency Medicine, Head Section of Healthcare Provider Empowerment. Kindly welcome Dr. Badr. Dr. Badr, the floor is yours.
Thank you, Hiba. My voice is clear.
Yes.
10 seconds to share the presentation. Hello, everyone. Thank you, Hiba. I'm very glad to be today with you. Thank you for attending this RCA workshop. Today, inshallah, we'll be presenting 4 parts or 4 lectures regarding RCA. Then at the end, we'll have a case study with Dr. Rakan Mughir. The objective of this course is to highlight the importance and different types of reporting, and also to highlight the SPSC Sentinel Event Manual, and to discuss the decision to conduct a root cause analysis and when should we conduct a root cause analysis, to illustrate the core component of a good RCA, and to explain process steps to complete an RCA. Then we will highlight the importance of patient and family engagement. Also, we'll discuss the importance of communicating improvement initiatives to staff, and to highlight supportive tool that will aid in your RCA process. As I told you in the beginning, at the end we'll have case study. So the first lecture is really about introduction. I'll be presenting the introduction with the following objective: the importance of reporting, the different types of events, the Saudi Patient Safety Center SPSC journal and manual, when to conduct an RCA, how to prioritize the events, and the characteristics of a good RCA. So to start with, why do we report and analyze events? So this should come in mind, each one of us, when we try to report and analyze events. What are the benefits behind that reporting and analyzing mechanism that we have? So as we all know, we need to learn from error, and analyzing patient safety events allows healthcare organization to identify the root cause of error and adverse event. By understanding what went wrong, organization can implement corrective measures and preventive strategy to reduce the likelihood of similar incidents and failure. Transparency and accountability, and this is really important. When we report patient safety event, it demonstrates the commitment to transparency within the healthcare organization. It allows the healthcare provider to openly acknowledge error, communicate with patients and their colleague, and it helps developed organization to benchmark their entities regarding their type of event. So if we report, for example, fall as one entity of patient safety event, if you have a transparency and a very robust reporting mechanism, you would be able to benchmark your facility against similar facilities. One of important thing regarding why do we report and analyze event is the return of investment. So a lot of studies shows that whenever we invest on reporting mechanism and analyzing events and building the teams, because it will take times, it will take time from the team, it will take efforts, training for the people to analyze the event. So it's really a costly procedure. But what they found that there is a clear return of investment when you invest more in reporting and analyzing events, because you will be able to avoid the next harm. So this is from last year Saudi Patient Safety Center Sentinel Event Manual. So sorry, Sentinel Events Platform. So in Saudi Arabia, we have the Sentinel Events Platform where hospitals can submit their Sentinel events. It takes them step by step through the portal to fill the case, the contributing factors, the level of harm, the age group, and it's really helpful to standardize these events. So if we look, for example, to the last year, we can find that the most common Sentinel events were between the age of 15 and 65, 57%, and the level of harm, 44% of these events was death. And our contributing factor in the platform were classified under 9 categories, which is communication and information, human factor, process issue, manpower, planning issue, equipment and technology, staff competency and performance, environmental factor, leadership and safety culture. And what we are noticing in the last 3 years, almost always communication and hands-off of information is an important issue regarding these Sentinel events. The Saudi Patient Safety Center yearly run a national project, which is the Hospital Survey in Patient Safety Culture. As we speak now, we are running the 5th cycle of the Patient Safety Culture, where we have all of our hospital, governmental, Ministry of Health, non-governmental hospital, private and university hospital, all participated on this national project through our platform. And again, this is the last year result. The top 3 potential area for improvement for most hospital were hospital management support for patient safety, response to error, and this is really important in regard to our talk today. Only 55% of the participants in the project, and the participant was more than 145,000. They report that they feel or they perceive that they are treated fairly when they make mistakes, and there is a focus on learning from mistakes and supporting staff involved in error. And the remaining 45 is clearly the opposite. They feel that there's a blame culture and there is no supporting program in place. We used, as you know, the AHRQ hospital survey on patient safety culture. We've translated it to Arabic language. And one of the question was, how many patient safety events did you report in the last 12 months? And this really was a surprise to us. Around 70,000 healthcare provider did not report any safety event in the past 12 months. And we can say that there are multiple factors, maybe the blame culture, maybe the reporting mechanism, it's not that clear. And really during my residency, when I was doing my residency in emergency medicine, I didn't report any safety events because of the reporting mechanism. Nobody orient me how to use the system, what is the benefit, and there is no clear feedback loop. So clearly, when you report safety events and then 2 or 3 days you receive an email or a thank you message for reporting safety events, and that we will work on it, certainly this will assure the healthcare provider and there is someone is looking out and trying to identify the patient safety events, and this is really important. So three important messages: feedback to the patient safety regarding the patient safety events reported. This is one important thing. Blame culture and moving towards more of just culture, it will help in reporting safety events. And the third thing is the reporting mechanism. Simplification, this more reporting mechanism, educating people regarding how to report and the importance of reporting is really matters. So let's go back and think where do error or mistakes fits in? It's either commission, which is doing something wrong, or omission, which is failing to do the right thing, and both of which will lead to undesirable outcome or a significant potential for such an outcome. What are the different type of events? We know that we have a near misses, adverse event, which can be again divided to preventable and non-preventable adverse event. As you know, the movement now towards trying to avoid the non-preventable adverse event as a term before labeling an event as a non-preventable adverse event. We should think twice regarding its preventability. One good example of non-preventive an adverse event that were non-preventable adverse event at one day, and today with the use of checklist, surgical bundle, it's totally preventable, and some hospitals in the USA reached to 0 events, is the central line associated bloodstream infection. Once it was non-preventable adverse events, nowadays we know it's preventable with better and evidence-based practices. So what is root cause analysis? Root cause analysis is the process of identifying the source of a problem, really looking for a solution in a way that the problem is treated at the root level. So we need to treat this problem at the root level other than walk around these problems and trying to blame people and do not look at the holistic picture of the system. And when we do root cause analysis, this really help the organization and professional to look beyond the symptoms of the problem. We are all in the medical field, and we know that the symptoms of the problem not always reflecting what is really exists and what is the real cause. So root cause analysis is really to move from who did that to what happened, why did it happen, and how to prevent it from happening again. So throughout this workshop with my colleague, Dr. Darfa, Dr. Rakan, Dr. Rawan, we will be answering this question: how to know what happened, and how to know why did it happen, and how really to prevent these events from happening again. So when we talk about RCA, the term itself, it's not really reflecting the process. So root cause analysis, because the first thing, it implies that there is one root cause. And most of the time, as we know from the data we read, from the reports and literature, the root cause most of the times is more than one, and we have many contributing factors that must be considered. The second thing regarding this term, it's only identify the process as analysis, root cause analysis. But what we are really doing is root cause analysis and building an action plan. So Why do we don't change this term? Because it's really embedded in the literature, and it's very difficult to change a root cause analysis as a term, and it might cause confusion. What we are presenting today is RCA square. This term was introduced by the IHI, and it's really trying to show the process in a holistic view. It's a root cause analysis, and the second A is action. So root cause analysis and building actions. So again, we can see in the picture on the left side, we have, and above the surface, you see the symptoms of the problem. You need, and we need all to dig deeper to find the root cause of the problem. As much as you find root cause that are related to the system, it would be better, and it would be really changing the game, because as much as system error we find, as much as system error we fix, the less adverse event we will have, because we treated and we have treated the issue at its root level. And again, remember that most of the time it could be more than one root cause. It's not always a one root cause. So regarding the sentinel events journey in Saudi Arabia, and I highly advise you to visit the Saudi Patient Safety Center, and you can find this manual that you can download. So in March 2021, it was the start day of this journey, and the manual was released in July 2021. We launched the reporting portal. September, the reporter start receiving the data, and since in December 2021, we released the first Sentinel event annual report, learning from the Sentinel events. And from those Sentinel events, we have identified target patient safety priorities. So, for example, improving Sentinel events reporting and analysis was the first priority, the surgical count, suicidal patient, blood product, and etc. 2022, we started to integrate with the Ministry of Health, because they have their own portal, and the journey is still continuing. So how did we develop this manual? In the beginning, we established a task force team. We did multiple mapping exercise with the available national and international list of the Sentinel events. We developed a proposed list of Sentinel events, including the methodology to report and the methodology to handle these events. And then we engaged all healthcare stakeholders to provide the consultations and feedback. After that, the initial draft was ready. We shared this initial draft with the subject matter expert, international and national, and with our stakeholders. We have collected the feedback on the initial draft, and after reviewing and editing the initial draft, the Saudi Patient Safety Manual was released. Three general inclusion criteria regarding this manual. One, the first, the event should be globally recognized as totally preventable and therefore never happen. The events include the failure of a system or processes, and then the event can be clearly measurable and identifiable. We came up with these 27 Sentinel event list. Every year we are conducting multiple workshops. The last workshop was yesterday, with multiple stakeholders and then at the national level, to review this list and to see where we can improve and modify the Sentinel event list. So one of the let's take two examples of our list. As we said, it's a 27. Number 3 was discharge of a minor patient to unauthorized person. So we can see here event description, clear event description. This event is intended to capture all cases where a minor patient was discharged to unauthorized parent or legal guardian, regardless of whether death, permanent harm, severe or temporary harm has occurred or not. And then you can see the inclusion and the exclusion. For example, here there is no exclusion for this event. Let's see another event, which is medication error leading to death, permanent or severe temporary harm. And here again, we can see the event description, the inclusion and the exclusion. And here, for example, when we see the exclusion, we can clearly see that the medication error related to unknown allergy, it should be excluded from this event. So how do we manage the sentinel event? The sentinel event here in Saudi Patient Safety Center. So starting is the internal reporting of the event to the responsible department. So this has been shared with all hospitals. Whenever they have patient safety event, they should internally report this event to their responsible department. They should review and match this event with the sentinel event definition that we saw, and also to see if it's a sentinel event or no. If it's not sentinel event, they should follow their healthcare facility policy, because as we speak, Saudi Patient Safety Center until now is collecting only sentinel patient safety event. So if it's not a sentinel event, they should follow their healthcare facility policy. So let's say it's a sentinel event. 3 major steps that these hospitals or quality and patient safety department should follow. First is to notify the healthcare facility governing sector within the specified time frame, and to assign the RCA team and to disclose the event to the patient and family. And we know this is very important, and my colleague will be talking more and more about patient engagement and how can we disclose the patient safety event to patient and family. So after assigning the RCA team, we conduct the RCA and the corrective action plan, submit the RCA and the corrective action plan to the healthcare facility governing sector and to the Saudi Patient Safety Center. And this should be within 30 working days. So an example of the manual, when you open the manual, the Saudi Patient Safety Event Manual, you will find at the end the way that we advise hospitals and patient safety and quality worker to proceed, and it really match our system or the portal. And my colleague Tarfa will go more in depth explaining these. But for example, you will find that the contributing factor is a process issue. There are triggering questions that help the one who is analyzing the patient safety events to find the root causes, and then to have the contributing factor, the corrective action, and the action strength. And again, we have 3 main type of action strength: strong, intermediate, and weak. And we will talk more about action strength as we go in this workshop. And it's very important to have a responsible person of departments and action at the time point actions. So when to conduct an RCA? So virtually, RCA can be conducted for any patient safety event. Can be conducted to sentinel events, serious patient safety event, near misses, incidents. But because of that sentinel events, it's really take time, and sometimes you have a multiple incidents events. And on the other hand, if you want to conduct a patient safety or root cause analysis for every patient safety, sometimes you cannot do this. So there is a 2 way to help you prioritize the patient safety event. So the ideal way is to analyze all patient safety event using the root cause analysis method. But if it's not possible, you have to have a prioritization method. Two main prioritization method are known as risk-based RCA or harm-based. Let's start with the harm-based. Harm-based is currently the most commonly used. The event must cause harm to a patient to warrant an RCA. So we only focused on that events that caused already harm. The second thing is risk-based. So it's try to prioritize the hazards that may not yet have caused harm. For example, the close call, the near misses. And this is really great practice, but it's not usually feasible. One good approach is to do a harm-based approach with supplementary risk-based approach using risk safety matrix. For example, the safety assessment SAC matrix. It's a rapid prioritization method for ranking hazards. So you are, for example, in your hospital, you will go for harm-based approach, and you will use this SAC matrix to prioritize some of the very high risky events to have an RCA for them. So the characteristics of a good RCA, this is really important. What constitutes a good RCA? The agent review should take less than 40 days to complete or 30 working days. And why is this? There is no evidence behind this, but most of the patient safety known institutions agrees that it should not be more than 45 days. And this is because of recall bias. People, they will forget about some information regarding the case. The second thing that you should have a contributing factor, and your contributing factor should have supporting data or information. So it should be based on evidence of data. For each contributing factor, you should have a root cause that comply with the five rule of causation, and we will go through the 5 rules of causation with Dr. Adarpo. Corrective actions for each root cause. This should include at least one strong or intermediate strength action. Action follow-up is assigned to person, group, or committee, responsible person or group for the implementation for each action, and the target date for completion of each action. If we go to the opposite page, what is the warning signs of ineffective RCA? It's totally the opposite. But why we are mentioning it here? Because whenever you have these warning signs, you need to re-examine or revise the whole process. For example, if you don't have a contributing factor, or if you have a contributing factor but it does not have supporting data or evidence. If you don't have strong or intermediate action, if there is no corrective action identified, or if the action follow-up is really not assigned to a group or committee, and etc. So these are the warning signs of ineffective RCA. By this, I conclude my talk. I don't know if we have any questions or comments before we go to the next lecture, or I don't know, they will write in the chat or. Hiba, if we don't have question, I'm ready to close the sharing, so my colleague can start the sharing.
Assalamu alaikum. So can I start now? Okay, so good morning, everyone. This is Rawan Sultan. Thank you, Dr. Badr, for briefing us about or give us an introduction about RCA, Sentinel event, and our platform. During my presentation, I will go through preparing for an RCA. So I will talk about the timing for RCA conduction, team formation, members and rules, as well how to collect resources, how to engage patient and family, and describe what happened. So at first, during the RCA process, as Dr. Badr said earlier, what is RCA? So RCA is a process for identifying the basic contributing factor that underlie variation in performance associated with adverse event or a close call. So it's a kind of specific focused review that used for all patient safety events. So now currently as getting starts, we have to create our team. At first, immediately following the event, we should take care of the patient, make sure that the patient is safe. This is our priority. And then the healthcare leader should direct or appoint an RCA analysis team in charge of the event analysis within 24 hours of the internal reports. It is the responsibility of the governing sector to submit a complete event, including the description of the event, the root cause analysis, and the corrective action within 30 working days of the internal reports. So the RCA team member should be between 4 to 6 members. It depends on the scope of investigation, but ideally it should be between 4 and 6 members. It should include a leader, a subject matter expert, a frontliner, and a root cause analysis facilitator. And then I will talk about engaging the patient and family. What is the responsibility of the RCA team member? The RCA team member responsible to provide a support to the patient, the staff involved in the event, to initiate the investigation process, to start interviewing the patient and family, and then they have to conduct the root cause analysis, followed by a corrective action plan, and then to report the complete event through the national platform. And also it is the responsibility of the RCA team member to make sure that the event was disclosed to the patient and family. What is the role of each member? So the leader is the one who is familiar with the RCA process, but the most importantly is to have the required knowledge to keep the team on track and aligned with the required component of the event investigation. The facilitator is the most expert one with the RCA process, with its milestones, and also to make sure that the team are following each steps during the investigation. The subject matter expert, the individual who is familiar with the area being investigated. So for example, if the event were in ICU or emergency, it should be an emergency consultant or ICU consultant. A frontline staff is an individual unfamiliar with the area being investigated and also not involved in the events. The aim of the team is to work in a complementary way. The members will provide the content, the facilitator will make sure that the team are following the correct process, and the leader to make the decision making. Okay, so now who's a member and who will be interviewed? Everyone can be a team member except the staff involved in the event and the patient and family. They have to be interviewed rather than being a team member. Okay, so now you created your team. You have to set for the first meeting. During the first meeting, the leader should orient the RCA member briefly about the events and to have a common understanding at first. It is recommended to have a greeting by a top manager to reinforce the importance of the team's work, and also to start with a simulated RCA video just to have a quick brief of the RCA process. During the first meeting, the members should decide on the meeting dates to avoid any possible delays, and also to set the expectation and the rules or the requirement of each member. And then they have to decide on the triage questions, which I will elaborate on later. So during these steps, we moved from getting started to analysis. During the first meeting, the most important thing is to draw the initial flow diagram, which is an initial sequence of the event outlined on a story that progressed chronologically from the first known fact till the final known fact. Start with explaining or establishing the series of events that preceding the actual event. This is highly important. It will help the team to discover what went wrong or what caused the event. Try to stick with the facts only. Use flip chart, brainstorming during the drawing the diagram. And also clearly mentioned what you know and what you don't know. Sometimes it is helpful to visit the scene, try to simulate what happened. So this is an example of the initial flow diagram. Just start with the event and fill the known steps that already the team or the members are familiar with. This is an example. So the patient admitted in the center, the patient went to X-ray, the patient fell from the X-ray table, the patient injured his knee, and then the patient ended up with additional knee surgery. During that meeting, you have to fill the gaps. So you have to answer this question. What went wrong? So was the patient risk communicated? Was the patient assessed of risk of fall upon admission? Was the patient risk communicated to the X-ray technician? And so on. So try to ask questions to fill the gaps following each step. So to complete the RCA, you have to focus or to answer this question. What happened? What did happen? What action can we take to prevent it from happening again? How will we know if the action we took made a difference? It's highly important to focus on the system and process. Try to go away from focusing on individual. Following the meeting, the team should start collecting resources and preparing for the interview. Start by gathering the information from the incident report, from the patient documentation, from the investigation. Try to interview the staff involved and also to sit with the family, listen from the patient, interview the patient and the family, and even to simulate the event. This is the triggering question which the team member should decide on during the first meeting. It's a set of 75 questions, cover the communication, training, and all the aspects that can be go wrong during the event. It's not necessary to go through all the 75 questions. During the first meeting, you have to decide on the relevant questions only. For example, to set a 10, 20, 30 questions to be asked during the interview to the family and also to the staff involved. Before the interview, you have to make sure that the interview will be conducted in person and each individual at a time. A maximum of 2 RCA team members conduct the interview. Try to pick a suitable area for interviewing the patient and family. Assert at the beginning of the interview the purpose that we are focusing on the system corrective action. Try not to blame or judge. Be professional during the interview. Avoid intimidation. Start your interview with a general open-ended question and try to make it as safe as possible. During the interview, try to listen and reflect what's being said. Build a confidence by restating and summarizing what you have heard. Keep an open body posture. Maintain a good eye communication. Try to demonstrate empathy with the patient. Do not judge, blame, or interrupt. If they have difficulty in remembering the event, just ask the staff to clearly state their routine during work. Ask them to write or to draw a sketch of the process. Emphasize on confidentiality, and this is the purpose of interview, completely to focus on system. There will be no blaming to the staff. So we know that I mentioned earlier about engaging the patient and family in the process of RCA. We know this could be challenging to healthcare leader, but this will add a lot on the RCA process. As the National Patient Safety Foundation, they released a report titled "Safety is Personnel" and partnering with patient and family for safest care. It is a call to all healthcare leader, policymaker, and the clinician to involve the patients and family in all levels of health care. The literature on this field is still growing, but we have an article by Zimmerman asserting that actively involving the patient and family in the post-event analysis will allow the risk management professionals to improve their organization's system analysis process by empowering the patient to be part of the solution, making them an equal partner with the healthcare provider. So if the organization are currently not mature enough to engage the patient, at least try to have a patient representative to be the patient voice during the investigation and during the analysis. And as I mentioned earlier about the disclosure policy, so SPSC, our center before we released a disclosure policy. This policy will help the healthcare facility to build their own internal policy based on their resources. And it is highly important to gain the community trust by having a transparency and to describe completely what happened to the patient following the policy. So this is all about preparing for RCA. The next presentation will be about identifying the root cause analysis with Dr. Tarfa. So if you have any question regarding my presentation, if you can please type it in the chat. Okay, thank you.
Good morning, all. We'll talk about identifying root causes. The outlines of the lecture is identifying root causes, identify contributing factors, and the root cause analysis tools. Previously, my colleague Rawan mentioned how to start the process of root cause analysis and starting with team formulation and starting the interview. Now we will move to how to properly analyze and identify the root cause and contributing factors. So after the RCA team has identified a system vulnerability, these need to be documented and written up to comply with the 5 rules of causation. These sentences should be written at the end of the RCA. When the rules are met, causal statement will be focused on correcting the system issue. The causal statement are written to describe the cause, effect, and event according to the 5 rules of causation, and we will take an example for each one of them. So rule number 1 is we have to clearly show the cause and effect relationship in that statement. And for rule number 2, we have to use specific and accurate descriptors for what occurred rather than negative and vague words. Rule number 3, human errors must have a preceding cause. Rule number 4, violation of a procedure are not root causes but must have a preceding cause. Rule number 5, failure to act is only causal when there is a pre-existing duty to act. We will take now example for each one of them. So for rule number 1, clearly show the cause and effect relationship. The example is in high volume of activity and noise in emergency department led to resident being distracted when entering the medication order, which increased the likelihood that the wrong dose would be ordered. This is the example. So how can we dissect it? The cause is the high volume of activity and noise in the emergency department. The effect is the resident being distracted when entering the medication order, and the event is increase the likelihood that the wrong dose would be ordered. So if we took this an example and we want to write the causal statement for that scenario, it's incorrectly to write a resident was fatigued. We have to specify why the resident was fatigued. And as we mentioned previously, we have to focus on the system issue. So the correct statement will be the residents are scheduled 80 hours per week, which led to increased level of fatigue, increasing the likelihood that dosing instructions would be misread. So now we know exactly where is the cause, and we can target that cause and write a corrective action plan for it. For rule number 2, use specific and accurate descriptors for what occurred rather than negative and vague words. So we have to avoid negative descriptors such as poor, inadequate, wrong, bad, failed, or careless. Referring to the previous example, it's incorrect to write the causal statement, the manual was poorly written. We have to specify exactly why it's poorly written. So the correct statement will be the pump's user manual had 8-point font and no illustrations. As a result, nursing staff rarely used it, which led to increased likelihood for pump would be programmed incorrectly. For rule number 3, which is the human errors must have a preceding cause, also referring to the previous example, incorrectly to write the resident selected the wrong dose, which led to the patient being overdosed. We have to write exactly what was the cause, effect, and the event. So the correct statement will be drugs in the computerized physician order entry statement are presented to the user without sufficient space between the different doses on the screen, increasing the likelihood that the wrong dose could be selected, which led to the patient being overdosed. For rule number 4, violation of procedure are not root causes but must have a preceding cause.
So we'll take now a new example. It's incorrect to write that the technician did not follow the procedure for CT scan, which led to the patient receiving an air bolus from an empty syringe, resulting in a fatal air embolism. The correct statement will be noise and confusion in the preparation area, coupled with the production pressure, increasing the likelihood that the steps in the CT scan protocol would be missed, resulting in injection of an air embolism from using an empty syringe. So now we know that the issue or the cause was in the environment around the technician. For rule number 5, failure to act is only causal when there is a pre-existing duty to act. So the incorrect statement will be the nurse did not check for stat orders every half an hour, which led to a delay in the start of anticoagulation therapy, increasing the likelihood of blood clot. How can we write it correctly? The sentence would be the absence of an assignment for designated registered nurse to check order at specified time increased that the likelihood that stat order would be missed or delayed, which led to a delay in therapy. So now we knew how to write the causal statements per the 5 rule of causation. Now we will move to how to conduct the RC and how to look for the contributing factor. The categories of contributing factors, we classified them in the SPSC manual into 8 categories, and the 9th is others. The first one is the process issue. The second one is the human factors. The third one is equipment and technology. The fourth one, environmental factors. The fifth one is staff competency and performance. The sixth one is the manpower planning issue. Seventh one is leadership and safety culture. The 8th one is communication and information. And in case there is, we couldn't classify our contributing factor in these categories, we will put our contributing factor in others. This is the example of the sheet in the manual. So for the category of contributing factor, we'll take an example so then the picture will be more clear for you. The first category of contributing factor is the process issue. We have to ask ourselves triggering questions till we reach what exactly is the contributing factor. So let's take an example. In process issue category, we can ask this question: what was the intended process flow? The second one, were there any steps in the process that did not occur as intended? Also, we can ask what were the steps in the process that did not occur as intended. So when we answer these questions, we can know what was the contributing factor. The contributing factor could be the aids not available, or it's not working, or maybe there is difficulty in accessing senior or specialist advice, or maybe there is lack of prioritization of the guidelines. So then now we know exactly what was the contributing factor. It will be our target to put our corrective action plan and start to improve. For the second category is the human factor. We can example for the triggering question: what were staff-related human performance factor relevant to the outcome? So maybe the staff was stressed. Maybe he had a lack of motivation. Maybe there is personal problems. So that we have to know exactly what was the factor. The third category is equipment and technology. Examples of the triggered questions: was available equipment and technology used as intended? How did the equipment technology performance affect the outcome? And also we can ask ourselves, in that event, were the personnel trained appropriately to operate the equipment involved in the event? So not targeting only the equipment itself. We also have to know if the personnel was trained on using that equipment. So the contributing factor might be the equipment is in an appropriate size, or it was poor working order in that system. Maybe the equipment was incorrectly stored, or maybe the correct equipment itself was not available. Third category is the environment. The fourth category is the environmental factor. Some of the triggering questions: how was the work area or environment designed to support the function it was being used for? So the contributing factor could be poor or inappropriate office design, or maybe there is inadequate security provision, so which led that making that healthcare provider doing or having led to that event. The next category is the staff competency and performance. So now we will move on to see if the staff was properly qualified to perform that duty. Well, we have to ask also if how was the staff trained staff training needs assessment conducted, or was training provided prior to start of the work process. We all know that prior to letting the healthcare provider starting their work, they have to have a brief assessment, brief training, how to work in that area, to know the policy, to know the protocols. So if we know that the staff was not trained properly, so now we will focus on train that staff. The contributing factor for that category could be the lack of skills. Maybe the staff was inexperienced. Maybe he was he doesn't have knowledge. Maybe it was unfamiliar task. He was asked to do a new task for him, and the staff was not familiar with that task. Then the next category is manpower planning issue. So some of the triggering question are was there sufficient staff on hand for the workload at that time? Maybe the contributing factor was the overload. One staff is handling multiple patients, and he maybe 7 or 8 patients, and he was supposed to handle only 3 patients. So this is a contributing factor. Maybe there is using of temporary staff, so the turnover of the staff is high, so now we have to hire new staffs. Maybe there is excessive external tasks for the staff. Now we have to divide the tasks for them, so to make each task to be done appropriately. The next category is the leadership and safety culture, and we knew the importance role of leadership in improving the systems and the culture in the institution. So some of the triggering questions are how does the leadership address the continuum of patient safety events, including close call, adverse event, and unsafe hazardous conditions. Maybe there is inadequate decision or action caused by the group influence. Maybe there is hierarchical structure. Maybe there is a professional isolation. Maybe there is lack of risk management plans. So once we have identified the contributing factor, we can work on it. The next category is the communication and information. So now we will focus our question on that category. Some of the questions are: was the patient correctly identified? How was the information from previous patient assessment shared and used by the treatment team members on a timely basis? Maybe the contributing factor was there's a language barrier. Maybe there is incomplete information in the patient's records. Maybe incorrectly used of language. Maybe there is a problem with the writing or entering the information in the record, so the record's difficult to read. Or maybe there is an inadequate patient identification. In case we have another contributing factor doesn't fit on any of the previously mentioned categories of contributing factor, we can write them under others and ask more questions to know exactly what was the factor. We will move now to the tools used in doing the RCA. I mentioned, I've talked previously about the SPSC tool, but it's not mandatory to use SPSC tool. You have multiple tools. You can use whatever you're comfortable with and helpful for you. My colleague Rawan, she talked about the initial flow diagram, and she mentioned that it should be started from the beginning of the investigation or the analysis. And throughout the process or the meetings of analysis, we have to have this flow diagram and write what happened exactly through that event until we reach to the conclusion and the final flow diagram, so that we know what is exactly the pitfalls and what is exactly the missing or the gaps we can to lead us to improve them and finding a solution for them. Another tool is the cause and effect diagram. This is a visual tool, and it is it will improve the communication with the stakeholder, because the leader, it's easier for him to see everything mapped in one slide or in one paper. It's used to identify and document the contributing factor. As I mentioned, it's not mandatory, so choose whatever tool is suitable for you. This is the example for the cause and effect diagram. This is after filling the data. So now you see that there is multiple the dissection of the event and finding the exact cause. Another tool is the 5 whys tool. Recently, they don't recommend using the 5 whys tool alone. It was discovered. This tool was discovered in car manufacturers. And it was helpful for them and finding the cause. But in healthcare, as you know, that it is a complex system. Using this tool alone, the study suggested that we can use it as adjunct to another tool, not alone. Because if we have one problem and we keep ask ourselves why until we reach the root cause, we will find only one answer. Otherwise, if we use it with adjunctive tools, so we can take each statement and write our questions until we reach to the final causes. Another tool is the sequence of event. You can write the event in a chronological way with the time, with the date and the time and the source of information, so that it will be easier to dissect the event exactly and what happened in that specified time. I finished my presentation. Thank you for listening. If you have any questions, you can ask in the chat. And after we answer the questions, you have a 20 minutes break.
Okay, good morning, everyone. My name is Dr. Rakan Al-Mughir. I'm the head of healthcare provider empowerment at the Saudi Patient Safety Center. I'll start my lecture today about the development of action plans and the RCA process. I know that you have went through the importance of reporting, the formation of teams, and the initial decision of whether this is a sentinel event or an adverse event. And then you went through the roles of the team members. Then you went through the meetings of the RCA team and the tools that can be used during the interview. And now we're coming to the part of developing action plans. So, as you may understand, action plans are the most important step. Why is that? Because system level actions that will prevent these adverse events from happening again are the target of the whole RCA process. So what we want from this RCA investigation is to prevent event from recurring or reducing its severity. One of the most famous tools that is being used in the RCA investigation is the action hierarchy by the National Center for Patient Safety and Veterans Affairs. It divides the action strength to 3 categories, which are strong, intermediate, and weak. Can somebody write in the chat, depending on what do you think the action is, strong, intermediate, or weak? Can you write in the chat, depending on, yes, excellent. So reliance on human by Yumna. So the action is strong, is considered strong if it is less reliant on humans. Intermediate, if it has some reliance on humans. Weak, if it has higher reliance on humans. And we will come to examples of this. So in here, you can see that the stronger actions include architectural and physical plan changes, new devices with usability testing, engineering control, simplifying processes, standardizing on equipment or process, tangible involvement by leadership. What do we mean by human reliance is that if there is a door at the entrance of the hospital that is causing too much injuries to the patients and visitors of the hospital, the strong action that you can take in here is replacing this door. So it has no human reliance and no human intervention to reduce this type of injury from the door. While if I put a sign at the door saying, warning, this door causes injuries, or take caution, this is a weak action. Why? Because the human has to see and understand the sign before acting on caution on opening or closing this door. Even if he does or she does take caution, he might get injured also. So this is how we differentiate between stronger actions and weaker actions. Intermediate actions, there is redundancy, increase in staff or decrease in workload, software enhancements or modifications, eliminating or reducing distractions, education using simulation-based training with periodic refresher sessions, checklists and cognitive aids, eliminating lookalike and sound-alikes, standardizing communication tools, enhanced documentation and communication. And there is a difference between redundancy and double checking. Can somebody explain it in the chat? We all know about double checking, but what is the difference between it and redundancy, which is the intermediate action? Double checking is considered as weak action. Excellent. So Kamar is Kamar and Dalia, they answered correct. It is independent checking. For example, if I have a high risk medication that I want to administer to the patient and I want to calculate the dose. So I'll do my own calculations and my colleague should do his own calculations with the respected steps. This is redundancy. While double checks, I do the calculation, my colleague checks my calculation. He will not go through the same steps I went through. Take caution also that warnings, new procedures or memo or policy and training, all of these are considered weak actions. So in the action hierarchy, for each root cause, I should find at least one strong or one intermediate. For each action, for each root cause, I should get one action. And the whole RCA report, I should get at least one strong or one intermediate action to be of high quality, that my RCA report is of high quality. Weaker actions, we can use them, but only for temporary time until stronger actions can be implemented. An example of this, if I want to implement a barcoding system or an electronic medical record system that will take 2 to 3 years to implement, I can use the double checking, for example, for the patient identity, etc., until the stronger action takes place. So human errors, they are not acceptable as root causes because many of the studies have showed that 90% or more than 90% of the adverse events are caused by system failures, not by human errors. The disciplining of a staff will not solve the issue. This staff will spend 1 or 2 or 3 or 5 years in the area or on the unit, and then he will leave. Another staff will come in and do the same mistake or be involved in the same adverse event. And for that, remediation and training are weak actions for the same reason. If I train and remediate this staff, tomorrow he will go to another unit or to another hospital, and a new team member will experience the same adverse event. So each action that I come up with, I should set a deadline for it to be completed. This deadline is being set up by meeting with the assigned individual on the action. So if the action has includes, for example, a barcoding system, or includes a physical architecture or renovation, I should get the engineers or the IT to give me the expected time that the action will be implemented. I will give him authority and access, and this is the importance of early leadership engagement in the RCA program at my hospital. Why we should not assign the action to a committee? You can answer in the chat. Excellent. Yumna is saying dilutes accountability and undermines the probability of successful implementation. This is the perfect answer. So there will be dilution of accountability or responsibility. And if I ask somebody, he will say, just go to the other person, he knows better. That's why we need an individual assigned to the action with his name or at least his position in the RCA report. So for each action, also, I have at least, I should have at least one measure. The measure statement should indicate what is being measured, by whom, the compliance, date of measurement, assessment. These four things. These four things should be included in the measurement statement in my RCA report. How many measures do we have to see the effectiveness or the implementation of an action? You can answer in the chat. Nashwa, I'm asking about the types of measurements that we have. The types of measurement. Yes, process and outcome. We have also balancing measures. For some actions, it is applicable, but the most commonly used types of measures are process and outcome. The structure, usually we don't use it as the action plans as a measurement to see the implementation of the action plans. It is usually either the process or outcome. In some situations, we need a balancing measure. So the time required for implementing the measure, it is the date of measurement. This is what we mean by that. So you will say that the action will take 3 months to be implemented, or it can be implemented now, and I will assess the effectiveness or the implementation in 3 months. So you should specify the date of measurement in your RCA report. Let's take this example, and I want you to come up with a process measure and an outcome measure. So let's say that I have in my hospital healthcare associated infections, and I implemented this action, which is staff use of alcohol-based hand gel before and after each patient encounter. I want to decrease the healthcare associated infections at my unit or institution. I want you to come up with a process measure and an outcome measure based on this 4 criteria. So we should specify in our measurement statement the reduction that we want or the increase that we want. So Kath is saying 100% of staff will do hand hygiene. This is a correct process measure. So it only lacks the period of time. For example, I will observe 100 patient staff encounters during a 7-day period with an expected compliance rate of 95 or 100%. This is how we come up with our process measure. The outcome measure, for example, I want a reduction in the healthcare associated infections. Let's say I have 50% rate of or percentage of healthcare associated infections of ICU admitted patients. So my outcome measure will be in 2 or 3 quarters, I will reduce the healthcare associated infections by 20% or 30% by using alcohol-based hand gel before and after each patient encounter. So what measure should we use first? Is there a better measure than the other? Excellent. Marisa is have typed in the chat correct outcome measure. So Dr. Mayer is saying process measures. So why do we implement process measures at first? Okay, he's saying because correct process will get correct outcomes. So not necessarily that correct process will get you correct outcomes. We implement the process measure early on in the actions because it is easier and faster to follow. I don't know now if my action have resulted in a better outcome or worse outcome. And this is one of the main things that we want to focus in our RCA. You will come up to a situation where you invent a new process or invent a new policy or procedure or system intervention that you're not sure of its outcome, whether it will lead to a better outcome or a worse outcome. So implementing a process measure alone will tell you that the process that you came up with have been followed, but did it result in an improvement or not? This is why you need to implement your outcome measure. Both of them are better, but in some cases, you cannot see the outcome of your action. For example, the HIS. You can indirectly reflect on the HIS implementation, but you cannot directly see if the HIS have resulted in improvement of the outcome or not. In that situation, you will have only a process measure, no outcome measures. The feedback on the whole RCA process and on the whole RCA program. Is it important? What are the benefits of the feedback, and whom should we give feedback to? Excellent. Kamar is saying important to encourage the culture of safety and reporting. Excellent. So we've been to a lot of hospitals in the kingdom, asking them about the issues they face, and one of the most important and prominent issue that they face in patient safety specifically, they say that when we report an incident, we don't get feedback about what happened to the investigation, what are the results of the investigation. So it is important, and it is a type of encouragement to the staff to report and to create a culture of safety. So feedback is important. To whom should we give feedback? Yumna is saying it should be provided to the CEO and board, service department, staff involved, patient and or family, and the organization as a whole. This is a correct answer. We should give feedback to all staff in the organization, from the frontline level until the C-suite level, where applicable. And we share the lessons learned and the areas to improve, rather than the negative wording or the negative disciplinary actions that has been taken to the staff involved in the incident. Keep in mind that we should keep the privacy and of the patient involved and the staff involved when we share the feedback with the whole organization. maybe you had an incident in one unit and there is a potential similar incident in another unit. Sharing the lessons learned from this RCA investigation to the other unit will help them prevent and mitigate the risks and contributing factors in such incidents. So leadership and board support. Who are the leaders? The leaders can be team leaders in the departments, the department heads, and above. When we present the RCA reports to the leadership and board, we should get their approval or disapproval. So if I get a disapproved action from my RCA investigation, what should I do with it? Okay, so Yumna is saying if an action is disapproved, the reason for its disapproval should be documented and shared with the RCA team. Excellent. And why is that? Why we should document the reason for disapproval? Convene and redevelop alternative actions. Excellent. Another reason? So it is like a documentation for yourself. If a future colleague comes from working in the quality and patient safety, or an external reviewer is reviewing your RCA report, he will see or she will see that you have suggested a strong action or an action that will result in an improvement, but it was disapproved for these types of or for these reasons by the leadership. So it is a documentation that will protect you as well as will provide you with alternative actions that will meet the demands of the leadership. So RCA results presented to the board and included in their agenda. This you should make this as a habit. We recommend that you put a frequent meeting, for example, 2 or 3 or 4 times a year with the leadership and board of your hospital to discuss the RCA program and the most notable RCA case or adverse event cases that you encountered during your RCA program. Action hierarchy and warning signs, they should be provided to the leadership to assess the quality of RCA in their institutions. Were there strong and intermediate actions in each RCA report or not? Were the causal statements were written in the 5 rules of causation to meet the 5 rules of causation or not? And this is how they assess the quality of the RCA program that they have at their institution. Also, there is an extra benefit to that. If they are handling more than one hospital, they can apply the corrective actions to the other hospitals. This is part of sharing sharing knowledge with other institutions and being a learning organization. So this is the warning signs that Dr. Badr have presented in the first lecture. There are no contributing factors identified, or the contributing factors lack supporting data or information. One or more individuals are identified as causing the event. This is what we call human error. No stronger or intermediate strength actions are identified. Causal statements do not comply with the 5 rules of causation. No corrective actions are identified, or the corrective actions do not appear to address the system vulnerabilities. Action follow-up is assigned to a group or a committee rather than an individual. Actions do not have completion dates or meaningful process and outcome measures. The event review took longer than 45 days to complete. There is little confidence that implementing and sustaining corrective action will significantly reduce the risk of future occurrences of similar events. The opposite is the measures that indicate that the RCA program is successful at my institution. Percent of contributing factors written to meet the 5 rules of causation. You can, as a quality and patient safety staff, present these percentages to the board so they can see that your RCA program is of high quality. Percent of RCA square reviews with at least one stronger or intermediate strength action. Percent of actions that are classified as stronger or intermediate strength. Percent of actions that are implemented on time. Percent of actions completed, and etc. So, as a conclusion, for the RCA program to be successful, you should secure leadership support in the beginning of the RCA program. The tips and tricks for that is that you involve them early on in each adverse event. You should make it as an agenda in the board meeting. Annual review of the RCA program, with providing them with the warning signs will secure their engagement. The blameworthy events should be defined clearly, and there should be a process to investigate any blameworthy events that are suspected to have human error. Formal risk-based prioritization assessment is recommended for institutions that have high rate of reports to prioritize which incident should I investigate first and which has the most impact on the system. And final note, to comply with the RCA timings, the initial reporting within 72 hours and the final reporting within 30 working days or 45 days. This is it for the recommendation for the development of action plans. Now we will move to the case study. So the case, and it is an interactive case study. We will go through the steps of the RCA together, and we shall reach to the root causes of this incident. So the incident is that a 65-year-old man who weighs 124 kg with an aortic stenosis and coronary artery disease. He got admitted to the hospital. He underwent a combined aortic valve repair and coronary artery bypass grafting. The post-operative chest X-ray showed small metallic object that was reported to be mostly retained foreign object. The treating intensivist reported this through the occurrence variance reporting system of your hospital. What will you do next? So save your questions for the last, and I will be able to answer them, inshallah. Excellent. So stabilize patient first. Tamer have answered. Checking on the patient, even if you are a quality and patient safety staff, just visit the ward or the room of the patient. Make sure that the patient was attended to during this adverse event. Make sure that all of his needs have been met and he is stable, in a stable condition. As simple as checking with the nurse if the physician have been notified about the adverse event and he has a plan to mitigate this event is sufficient. So what will you do next? So Tamer is saying meeting with the involved staff. I think there is, or there are multiple steps before we meet with the involved staff. So formulating a team. Excellent. So some institutions, it depends on your policy, whether you formulate your team first or just check with the whether this is a sentinel event or not. It depends on your institution. So we prefer that the internally the quality and patient safety will review this incident the documentation and whether it meets the sentinel event definition or not. So what do you think about this case? So there is an internal reporting. There is now we are matching the sentinel event definition. Does this case fulfill the as a sentinel event or not? Excellent. So we can see from the definition that this case is a sentinel event, and it's not one of the exclusion criteria. So now we should notify the healthcare facility governing sector, assign our RCA team, disclose the event to the patient and family, depending on your disclosure policy. Some people they have the initial and final disclosure. Some institutions have only final disclosure, and we can skip this step. So now assigning the RCA team. In this case, whom are the team members that you want to involve and what are their roles? So who's the subject matter expert that you want, Sarawat? So Kath is saying quality and patient safety, excellent. OR head, excellent. Scrub and circulating nurse. So is it somebody involved in the incident or somebody just exposed to the same conditions as the scrub or circulating nurses? So Daria is saying cardiac surgeon or nurse, quality and patient safety. So Ghaida is saying the involved in the incident should be team members. So this is what we don't want in the RCA team. Nobody involved in the incident should be part of the RCA team. Why? Because they will have conflict of interest. There will be hidden informations and there will be some legal aspects to that. That's why we don't want them to be members. So not involved in the incident, but exposed to the same conditions are the best way or the best staff to include in our RCA team. So in summary, we will need at least 4 persons. The team leader should be somebody who is well versed with the RCA and have the skill to keep the team on track and have the ability to make decisions. Some hospitals, they assign the director of quality and patient safety. Some institutions, they assign the department head of the involved incident. In this case, the cardiac surgery department. And here we can say that the quality and patient safety director or head can be the team leader. The facilitator should be one of the quality and patient safety staff who is well versed with the RCA process. He has the communication skills with the other team members, can collect the facts and secure the evidence to facilitate the RCA team investigation. The third person is a subject matter expert. We can get a cardiac surgeon who's not involved in the incident as a subject matter expert. We can also add other subject matter experts upon needed, either as team members or for interview. For example, the anesthesia or the radiology or the ICU as part of the RCA team. The last person is a frontline staff, whether it be a circulating nurse or a scrub nurse who is not involved in the incident. Now we have 4 team members. You can increase it to 6 if you need more staff, for more frontline staff, for example, or more subject matter experts. So as I said, if you need more than 6, for example, you can interview them. I remember one case we needed 5 subject matter experts. We could not include them all in the RCA team. We just interviewed the extra 3 persons that we need. So this is the schedule presented by Dr. Rawan Sultan in the second lecture. We can see that staff directly involved in the incident, they should not be team members. They should be interviewed only. The patient involved in the incident and their family, they should not be part of the team. They can be interviewed if applicable. So now we've reached to, we formed our team. We've identified that this incident is a sentinel event. What should we do in the first meeting? So Yumna is saying initiating flow diagram. Okay, that's acceptable, but there are steps before that. Orient staff about RCA and start flow charting. Yes, excellent. So just-in-time training for people who are not well versed with the RCA. We give them like a 30-minute orientation about the RCA. How are we doing the RCA? And assure that we are not looking for blame or failures of people. We are looking for system failures, just to shift the focus to the system rather than the people. Then we begin the review of the incident, give them a brief about the incident, what happened exactly, whether it be through papers or drawing the flow chart. We prefer that it is visual and visible to all of the staff. We draw the initial flow diagram, beginning from the most important step, or in this case, for example, the admission of the patient, until the incident happened, which is the retention of a foreign object. Up to our knowledge, this is why it is called initial flow diagram. Up to our knowledge, these are the steps or the events that happened to the patient presented in the flow diagram. After that, we identify the gaps of information that we have. Why did the physician did that and did not do that? This is a question that needs to be asked during our interviews. So how the patient was shifted from, for example, from the OR to the ICU. Was there a timeout? Was there a counting, a surgical counting or not? These are all the steps or the information gaps that we need in our initial flow diagram to ask during our interviews or to collect through the patient file. This will help formulate our questions that we need during for the interviews, and help us after this meeting go and collect the information that we need. So an important step or a tip that we advise to do is that you draw just close to the initial flow diagram, the ideal flow diagram, or what should have happened. For example, in here, the surgical count. This is what should have happened, the ideal process. The swabs and other items prior to commencement of surgery by 2 registered nurses, counting for all additional swabs, needles, instruments added to the field, counting for all used and unused and others prior to closure of cavity, final count performed before closure of skin and confirmed after skin closure. If there is in any of these steps discrepancy noted, we will hold the skin closure and call for X-ray. Is it detected by an X-ray or not? If yes, we will remove. It will be removed by the surgeon and then skin closure. If not, second navigation by surgeon under the skin and double counting by scrub and circular nurse. If it is found or not, there will be a skin closure and reporting of this incident. So in this case, I want you to just ask as many questions as you want in the chat, and I will answer them to help you reach out to the root causes of this incident. So let's begin with the surgical count ideal flow diagram. So Tamer is asking, does it mean 2 in 1 flow charts? No, you draw 2 separate charts. One is the initial, up to your understanding, up to your knowledge of the case. What happened to this patient? The other chart should indicate the ideal process or the ideal flow that the patient should have during this type of incident. So an unknown user is asking, is there a clear policy for timeout? Yes, there is a clear policy for timeout, and it has been conducted. So Aura is asking, did the staff utilize the checklists or completed? Yes, the timeout and the surgical safety checklist have been utilized, and there is no issue. So you are asking the staff about what happened. So she's saying that we got the patient from the ward, put the patient on the table. We did the timeout. We did the surgical counting at the beginning of all the swabs and the equipment that are being used. The surgeon have started the surgery, inserted the valve, and upon insertion of the valve, the surgeon have noticed that this is a new valve. They did not. He was not informed that it has been brought, and he did not receive specific training on this valve. For that, he did not know that there is a missing piece inside of the patient when I did the surgical count at the beginning and before the skin closure. When we asked for a chest X-ray, we are trying to follow the algorithm presented to you. When we asked for a chest X-ray, they told us that chest X-ray is damaged since yesterday, and there is no backup X-ray in here. I heard later on from the OR head nurse that she called the ICU and emergency and the radiology department to ask for a portable X-ray, and they said the ICU and ER portable chest X-rays should not leave the area, and there is no backup chest X-ray. So this is in brief what the nurse have told you. Do you have any other questions? So yes, Aisha, the team, the RCA team have confirmed and verified that the answers and the checklists have been done upon checking the documentation and file of the patient. So do you have any other questions to elaborate more about this case? I want you to reach out to the root causes of this case. So is there any distraction in OR at that time? There was no distraction. The environment was the usual. There were enough staff. We usually do the OR by 9 staff from nurses, anesthesia, and surgeons, and we have enough staff at that day. The temperature was good. The lighting was good. There was no distraction. The only issue is that as a surgeon, I was in a hurry to finish all the cases because my colleague got sick leave today, and one of his cases have been assigned to me. I usually take 6 cases per day, and today I have 8 cases. One for my colleague who's sick leave, and the other from the emergency department. So Aisha is saying 5 whys. Yes, ask the why that you want. So Tamer is asking about team communication. So the surgeon tells you that I was informed by the scrub nurse that there is a missing metal piece that we need to look for. And I have looked through the patient chest when they told me that the X-ray is broken, but I did not find anything, or I did not notice that there is a metal piece. So I communicated that back to the nurse and to the circulating nurse, but we could not find it. Yes, Yumna, they performed the surgical checklist correctly by interview and by documentation. So Ghaida is asking about competencies. Yes, all competencies have been done to the nurses and to the surgeon, and they do it yearly, and we have documentation for that. Excellent. So somebody is asking why the new instrument was not known to the surgeon. Kath is asking. So upon further questions to the OR head nurse, she told you that the purchasing department, they brought to us this new valve, which I did not notice that it is new. They did not inform us through emails or official communication that they brought a new valve. They put it in the stock and I signed. When you went as an RCA team member to ask the purchasing department, they are telling you that we usually do it this way. We find an FDA approved instrument and it is cheap. We buy it and supply it to the hospital, and we did not face any issue before. But we're not obligated as a purchasing department to train or inform any department of the equipment that we buy. So Aisha is telling they are obligated. Okay, so the policy they have, they don't does not mention anything about involving the respected department that you will buy the equipment for. So Ghaida is asking, is there any approved policy or policy regarding the new instrument? No. Excellent. So we've reached to one of our root causes, is that there is no policy regarding the purchasing of a new equipment to involve and train the respected department on the new equipment or instrument. So this is one of our root causes. Excellent. Yes, Ghaida. There is no policy for that. So FEMIA of new equipment not done. No. No one was informed about the new equipment. So their usual practice is that they buy the things that they see FDA approved and cheap to the hospital without involving the concerned department. And they are not obligated to involve anybody by policies and procedures. So we've reached to one of our root causes. Look for another. So what is the max number of each of patients for each physician? Excellent. So it is 6, but the patients of the sick leave physician are already admitted in the hospital, and they are prepped for the surgery. And the department head have assigned each of the patient on the other colleagues, one to this surgeon. Yes, so one of the root causes or the contributing factors is duty overload or cases overload or work overload. Yes, exactly. And this hospital, they don't have a rescheduling system for the cancelled cases. And this is one of the root causes that we have reached. So now we have two of the root causes. Yes, there is no contingency planning for overload of OR cases. Yes, there is no rescheduling of cases, and there is no on-call rota for the physicians during working hours. Okay, no backup for X-ray machine. Excellent. So when you asked the OR nurse, she told you that we have reported 2 days ago that this X-ray machine is not working. The biomed came and assessed the X-ray machine, and they labeled it as damaged and not working at all. And they advised to request for a new X-ray machine. The X-ray machine will take 1 week to arrive to the hospital. He called the ICU and emergency departments and the radiology department for portable X-rays, but they told them that the X-ray machines are assigned to this areas. They should not be moved from these areas. No regular PPM. Yes, there is regular PPM, and it is done, but this X-ray was damaged regardless. Okay, so what is your root cause in this case? So yes, the third root cause that we have, we don't have a backup X-ray machine or a flow chart or a process for getting a backup X-ray machine from other departments. And this can be generalized not only to the OR, even to the ICU and emergency departments. And this is part of spreading the knowledge and being a learning organization. So establishing a new pathway for getting a backup X-ray in case you have a faulty X-ray machine at your department is one of the solutions. So no backup X-ray machine is the third root cause. So I think the root causes that we have reached are enough. We've identified only one contributing factor, which is the workload of the physician or the team. Do you have any other contributing factors to this condition? Whether it be in the process or in the equipment or in the communication, etc. So the staff knowledge, the surgeon has spent 20 years doing the same type of surgeries. He's done the competency assessment, and he's a well-known surgeon. The nurses, the first nurse is a junior nurse, not a junior nurse, but recently joined nurse to the institution. She has 7 years experience in cardiac surgeries, but she joined the institution 3 months ago. So the proper implementation of the WHO Safe Surgery Checklist, they implemented it, and there is clear documentation that they followed the checklist. So the nurse should be under supervision by a senior. Yes, she is under supervision by a circulating nurse who's a senior to her. The surgeon only knew that the new instrument is new when he inserted the valve. So when you asked about raising the concern to the OR head or the department head to the recently joined nurse, she told you that I was not comfortable disclosing this to higher people in the hierarchy. I thought that my senior would do it, and I was afraid. So what do you think about this communication? Is this a root cause or a contributing factor? Excellent. So the safety culture for this staff is, or for this organization, is a contributing factor to this incident. Being afraid to go up in the hierarchy to report a safety issue is a concern for safety culture, which is a contributing factor. So this case is just an example of how you conduct an RCA and how you reach out to your root causes. The most important tool that I would recommend all of you to use is the 5 whys. If you keep asking why, you reach out to your root causes when there is a dead end. You cannot answer why anymore. The contributing factors are factors that help or mitigate the incident or the risks in the incident to for the adverse event to happen. So mitigating the contributing factors will create like a barrier for the root cause to happen or to affect the incident and result in an adverse event. Now we will move to the actions that you will need to undertake in this incident. I just want to highlight that when you write your causal statements, which is a cause that led to an outcome, you should make it in a way that comply with the 5 rules of causation. Why? For anyone to come up to read the report after you, whether it be within the team or outside the team, will understand exactly how a cause have resulted in an adverse event. And I think Dr. Tarfa have explained well about the 5 rules of causation. So what actions you want to undertake to mitigate the root causes and contributing factors. So let's take, for example, the purchasing department policies and procedures. So developing a policy and procedures is a way of solving this issue. What can I do to make the policy and procedure stronger action? Because you know that policies and procedures and new policies and procedures and memo are only weak actions. Excellent. Redesigning the process of purchasing new items. So one of the suggested actions that we've received through our workshops is that you design the form of the policy and procedure to have a co-signature of the department head. So in this way, we forced the purchasing department to get the signature of the department head to of the new equipment, and by that way, the department head will know that there is a new equipment coming to his department. Excellent. So include in the action plan the demonstration or training about the new equipment. Excellent. So apply human factor engineering principles. Excellent, but would it matter in this? Would it be possible in this situation? So I will design the new process according to human factor principles, yes. But if you mean the valve itself, it depends on the manufacturing company about the valve. They should use the human factor principles. Excellent. So we've received now 2 actions that at least intermediate in strength for one root cause. Let's go to the staffing or workload root cause. Excellent. Yumna is saying increase in staffing, decrease in workload as an intermediate action. What are you going to do in this situation? So Amani is saying rescheduling ORs. Excellent. So you will have a system for rescheduling or canceling the operations for sick leave or non-attending surgeons or physicians. Or even non-available equipments. So you'll have a system for these types of cases. Should do a workload analysis for OR. Excellent. So this is one of the proactive approaches for mitigating these contributing factors. So you can see that you can make innovative ideas of the root causes, and you can come up with multiple actions for each root cause and for each contributing factors. Let's go to the X-ray machine. What are you going to do? Yumna is saying make float staff available to assist when workloads peak during the day. Excellent. So a backup surgeon, for example, or an on-call surgeon during daytime or work time to assist in the cancelled cases. So you will choose whatever is suitable for the institution. Make backup plan for all critical equipment. So as simple as creating a flow chart or a process for getting a backup X-ray from other departments or borrowing other departments' machines or equipment is a temporary week action that you can implement until you get your X-ray machine next week. After that, you can get a backup X-ray that you can store in the storage as backup. Review the contract with company to ensure fast response backup machine. Excellent. So these are one of the solutions, but you can tell that when you implement this action, it might happen again if you deal with another company or another device or staff. So unifying devices in all departments is one of the strongest actions. Yes, it can help, and it will help in this case also. Any other action plans? Excellent. So after the action plans, you should put in your RCA report the measurement that you want, keeping in mind the 4 elements. what is being measured, by whom, the compliance, and date of measurement assessment. These should be in the RCA report and should be implemented at the exact date that you want to implement the measurement. By this, I conclude my sessions. I hope it was an interactive and interesting session. I hope you get benefit from that. I'm happy to receive any questions regarding my lecture or other lectures. Ms. Hiba, the mic is yours.
Thank you so much, Doctor, for this informative explanation. Dear guests, dear participants, we will have a 40 minutes break and then we will continue our presentation. Thank you.
I think this is the last part of the session, Ms. Hiba. I want to receive any questions regarding the workshop. If you have any questions, Dina is saying, could you please tell me the difference between the root cause and contributing factors? So the root cause is, let's imagine that you are in a room, okay? And you have gasoline spilled on the floor. You have, for example, gas being sprayed in the air. And you have a lighter. So if there is a burn that happens in this room, the gasoline and gas are all contributing factors that exacerbated this condition. But the root cause is the lighter that you have in your hand. I hope this example makes it clear for you. So whenever you investigate a case, anything that helped in reaching to the adverse outcome or helped in contributing to this outcome will be considered as a contributing factor. For example, failure in communication, failure, non-existence of policies or procedures, no alarms, no periodic maintenance, for example. All of these are contributing factors. But when you want to identify the root causes, you will find that it has a clear correlation that the lack of this device, for example, or the lack of this policy and procedure will have resulted in many consequent events that led to the adverse event. Any other questions? So Yumna is saying she has 4 questions. How can we analyze the safety incidents that we cannot perform root cause analysis on due to limited resources? So if you have many, if you mean by this question that you have many incidents at your institution that you don't have the resources to investigate all of them, that's the time you should implement a risk prioritization system. By implementing this risk prioritization system, you will quantify by numbers which incident you should investigate first, which has the major impact on the system or the patients, and you investigate it to mitigate the risks of this incident. For effective interviewing during RCA, is it better to prepare questions in advance or to just let the interviewee tell their story without making them feel interrogated? Excellent. So it is a mixture of both. When you start, it is better to prepare the questions that you want. When you draw the flow diagram, you will identify the gaps that you want to learn more about in this incident. You will prepare and write down the questions that you want, but you start your interview with letting the interviewee tell their story and why did they make these decisions, what made them make these decisions, to be exact. Not to feel interrogated, not to feel blamed during the interview. What is the difference between causal factor and contributing factor? I think I have explained this to Ms. Dima. And does causal factor mean the root cause of the event? No. Or are they two separate concepts? So we have contributing factors and root causes. Root causes are the beginning and the root of the issue that we have. While the contributing factor is an instance or situation that helped reach out to this adverse outcome. The last question by Yumna is, should we share the RCA reports and recommended corrective actions with SPSC? I think if you are obligated, if you are obligated by the governing sector to report to SPSC directly, you should report the whole RCA report, including the background of the patient, explained in details, the incident that happened, the investigation that happened, what root causes have you reached to, the contributing factors, the causal statements written to meet the 5 rules of causation, and the action plans with the respected dates of implementation. So depends on your internal policy. If you're obligated to report directly to SPSC, you should report. Some hospitals, for example, the Ministry of Defense, they report to the Ministry of Defense Health Services, and Ministry of Defense Health Services, they report to us. So unknown user is asking, is it always the QPS manager should be the team leader? No, it depends on your institution. If he is the most expert and he has the decision-making capacity, no one has this skill. He can only be the team leader, but anyone can be the team leader if he is well-versed with the RCA process, can keep the team on track, and have the decision-making skill. How to encourage the staff to report? One of the things that we mentioned during our lectures is the feedback. Providing feedback on the incidents that have reported to all staff will encourage the staff to report. Also, the measures to ensure the safety culture and just culture of the staff are evidence-based recommendations to encourage the reporting. non-avoidable harm of patient. How can we make an RCA action, for example, an intestinal injury happened during cesarean section due to adhesions from previous surgeries? I'm not that expert in the gynae procedures, but if it is preventable, and this is what the result of the investigation says, innovative and action plans should be implemented to make sure. Before that, you should make sure that you have reached to the root causes that for this incident. For example, if the gynae physician have been working for 24 hours and he made this mistake, so you should the root cause in here would be the workload and the long working hours instead of being it non-avoidable. And I think Dr. Badr have explained more about non-avoidable harm, that there is in the literature a lot of debate that there is no such thing as non-avoidable harm. And the reference story is that CLABSI, the central line associated bloodstream infections, was once believed to be non-avoidable until a bundle came, which includes hand hygiene, sterilization of equipment, and hands wearing PPEs and etc. And there was a reduction of CLABSI events. And at that time, they believed that it is preventable. There is no such thing of non-preventable events. Thank you all for joining, and we'll see you later. Please make sure that you fill out the evaluation survey for us to improve this workshop.
Thank you so much, Dr. Rakan. Dear participants, on the behalf of the Saudi Patient Safety Center, we would like to thank our dear speakers for their enlightening and informative presentations, Dr. Badr, Dr. Rawan, Dr. Tarfa, and Dr. Rakan. Many thanks to our dear audience for their active participations. And as a part of the Saudi Patient Safety Center efforts to provide you with timely topics and interesting speakers, we would appreciate it if you would fill out the evaluation surveys that's sent through the chat, and you will also receive another copy through the email. Thank you so much again, and see you later.